and welcome to another edition of the JASN podcast. I'm Kurella Tamura, a deputy editor of clinical science at JASN and professor of medicine at Stanford University. Today, we're diving into how medical treatments scale across the nation. If you were to ask a layperson, they would assume that access to life-extending medical therapies is expanded quickly and evenly across all or most U.S. communities. And certainly if we're talking about therapies that have been around for 10, 20, or 30 years, therapies like peritoneal dialysis, what we're going to talk about today, most people would assume that everyone who could benefit has access to these therapies. Yet historically, if you were in a high-income zip code in the West Coast, your chances of using peritoneal dialysis, a home-based treatment promoted for its flexibility and lower costs, are much higher than if you live in an urban zip code in the Northeast. So today we're going to talk about an exciting new study in JASN titled Peritoneal Dialysis Initiation Patterns by Health Service Area during an area of an expansion. And to join me in conversation is Dr. Christopher Knapp from the University of Minnesota. Welcome, Dr. Knapp. Can you introduce yourself?
Yeah, hi, and thanks for having me on. I am Christopher Knapp, as was mentioned. I'm a kidney doctor, and I work with the USRDS which is the nationwide dialysis registry at Hennepin Healthcare, and I'm a professor of nephrology at the University of Minnesota.
So glad to have you here today. So I'm going to dive right into the topic. I think most U.S. nephrologists know that the federal government began a massive push to expand home dialysis somewhere between 2009 and 2011 through a combination of payment incentives and executive orders. Can you just remind our listeners what incentives were introduced and who were they designed to influence? Dialysis providers, the physicians, or the patients?
Yeah, I think I came into practice, just a few years ago, and so all these changes happened well before, back in 2009, back in 2010. So I wasn't personally impacted by them, but what we did see, there's been two separate pushes towards peritoneal dialysis, right? And this study really covers the first push, which was in 2009, 2010. The federal government changed how payments were made to dialysis units, which influenced providers, but really it was I think the main target was the dialysis organizations and the dialysis units because they changed how they pay people. Basically, it used to be like you get some money for providing some EPO, you get some money for providing the dialysis, you get some money for providing certain other medications, and that was sort of an a la carte dialysis. And we decided in 2009, 2010 that we wanted to bundle payments, the part of why that really impacted peritoneal dialysis was there wasn't payment equity between hemodialysis and peritoneal dialysis before that for a large number of reasons. Part of it was, probably the biggest, most impactful things were PD patients don't tend to need as much EPOETIN, and PD patients and we didn't pay for home training for training purposes. Those two things got changed with the rule starting in 2009. They kind of knew that we knew the rule in 2009 and we started the rule in 2011. So those were the biggest changes, and those were really effective. If you want me to, I can kind of go through what happened in the last 4 years, which is a totally different set of changes. It was in flux as of even last year. But yeah, those were the changes that I was looking at in those study, that first set of changes.
So as I understand it, the bundle is really trying not to make PD even more lucrative. It's just trying to level the playing field.
Right.
And make it less of, basically just trying to level the playing field, as you said, create payment equity.
Yeah.
I think it would be helpful to just maybe encapsulate like what's happened in the last 4 to 5 years, the Kidney Health Executive Order in 2019 and some of the other policies that have been come out, and how might they touch on PD in the more recent years?
Just for context, PD came out in the 80s. There was some interest. It came out in the 80s. It emerged in its more or less modern form in the late 1980s, and was basically flat around 4 to 5% dialysis user, a little bit less than that for 20 years and leading up to 2009, 2010. And then we've seen since then, we saw a doubling in the last decade that has gone along with these changes. We can't say, of course, it's causing the changes, but it went along with it. But that still puts us below where many of our peer nations are. And in fact, there's some nations that use predominantly PD to dialyze folks. East Asian countries primarily, but like Thailand and Hong Kong come to mind as countries that use mostly PD. So in 2019, the federal government thought this isn't good enough, and we're not transplanting enough patients, and we're not putting enough patients at home. So they kind of mixed those two outcomes. They thought we're not, and they changed payment models to encourage more transplantation and more peritoneal dialysis. This was the whole ESRD treatment choices, to use their word. And so that really got started in 2021 and ended last year with the change in administration. And that was about changing how a third of the dialysis units in the nation were involved in this, and they were given payment incentives to incentivize home dialysis and transplantation. And other research that I was involved in, and the other author groups have looked at, has shown that has not really moved the needle to nearly the same extent that the bundle payments changes did in 2011. And I think that has a lot to do with, for one, the magnitude of the payments was not that much, and for two, this was really about making it equitable. Had a big change, making it just a little bit more for payment. It really changed how we do peritoneal dialysis in this country. It didn't make as big a difference if we said, oh, we'll give the providers a little bit more money, or we'll take away a little bit more. That didn't really move the needle for people to alter how their practice is with respect to who's on PD.
I see. So let's talk a little bit about the study. Your study evaluates geographic changes in PD use from 2011 to 2020 at the level of a health service area. So can you tell us a little bit about what are health service areas?
Yeah, so health service areas are basically counties or groups of counties centered around a hospital. So like one county that's centered around one hospital, or if it's like, let's say it's Midtown Manhattan, that's still just one county, and that's one health service area, even though many, many hospitals there. Whereas if you look at the other end of the spectrum, there are health service areas that cover rural areas where there's only one hospital and it's several several counties. So they are groups of counties that are related with respect to healthcare. Basically, I think the way we think about them is like healthcare catchment areas is basically how we think about them. And there are about 800 of them in the United States. So it's a lot easier to study, though. I mean, if I tried to study PD at 3,000, within every U.S. county, I'd run into, there are just so many counties where there's like one PD patient, maybe even none, right? And if you try to study at the level of states and like regions, you don't really get that information about what's going on at the community level. Those are much too big. So health service areas for this question were like a sweet spot for us. So that's why we decided to look at it.
I see, that makes sense. So they provide an insight that a broader study couldn't get at.
Yeah, I mean, I think that we want to know, I mean, there's so much of PD practice, regional and even community level. I mean, one physician group may be very incentivized may have champions that really want PD to be for most people, like want PD for most of their patients. Another community may not have PD services in their community, in a hospital, or may just have gotten them, so it's really, we wanted to see what was going on in a more granular level. And I think we did get some insight. Of course, it's always complicated when you try to look at things like that, but I think we got some good insight from it.
So your study benchmarks the start of this expansion era to 2011, as we said, coinciding with the federal reimbursement changes. At that time, what were the characteristics of low PD use health service areas? And then a follow-up, what were the most striking changes in PD use that you observed from 2011 to 2020?
I think if I had to take away this one thing from this study, is that there was not a complete level, like the playing field for PD is not completely level, but there was a leveling of the playing field. Because back in 2011, your high PD use areas were much more likely to be rural areas. They were generally a little bit wealthier. They were generally had less socioeconomic and racial diversity, and they were also less populous. Whereas your low PD use areas tended to be more densely populated, tended to be more diverse, and tended to have were concentrated in certain regions of the area of the country too. And those regional differences didn't really go away as much. We still saw if you were in the Northeast and you were low, you used relatively less PD in 2011, you still saw that in 2020. But in some other areas, we saw a real improvement. Yeah, I mean, I think that that was what our main goal was, just to see like how would these low PD areas, how much growth would we see compared to the other areas. So
And I guess it wasn't really obvious when you started the analysis that the growth would have happened in the low PD use areas. There's an alternate hypothesis here that if you put more money on the table, or at least bring parity in the payment system, that would incentivize the places that are already doing well at PD, at least relatively, to do more of it.
yeah.
And the communities that have a less PD still don't have the resources or expertise. So it wasn't necessarily obvious that
I mean,
that was,
I don't view it as obvious. I mean, I hope
yeah.
that, I mean, it's hard to like retrospectively put yourself in the mind before you got the results. But back when we were starting this, it's easy to think of like back then, many nephrologists were not doing PD as a part of their regular practice, you know, and many were not, didn't feel prepared to do it because they didn't get trained on it because there really wasn't as much. So it's easy to imagine a situation or to think of a hypothesis where the physician groups and the dialysis groups that already did PD, just those were the communities with more payment, they were able to find more people to do it. So we were kind of that was what we thought going in was we would see sort of the rich get richer in some sense. Like we would see that the places where there was the most PD, they would already find they would continue to grow at a faster rate. And so we were pleased, pretty happy that there was more growth in the lower PD areas.
Yeah. I mean, one of the piece of data that you report that I find really striking is that more than half of the health services areas that were considered low use areas in 2011 became medium or high use areas by 2020. And that really speaks to the, leveling of the playing field, or to, some alleviation of disparities, at least at the geographic level. So I guess that leads to a follow-up question is that does the attenuation of geographic disparities imply that there's also a reduction in socioeconomic disparities in PD use or access?
I mean, I don't think it doesn't quite. And one of the reasons I wanted to look at HSAs was because, I did other studies at other times where we looked at racial or economic disparities just as themselves, and how did those change? And those really didn't change as much as PD use at the community level, which is what we're looking at here, did change. So, I mean, it always makes you wonder, is the story, if you kind of combine not a lot of change in those disparities in the racial and economic diversity themselves with a lot of change in the community at the community level, I mean, it makes you wonder, are we just in more communities finding the same types of patients that we didn't look for before, right? Are we going to these lower PD areas and these previously lower PD areas and just finding wealthier people or more prepared patients? That's certainly possible, frankly. I still think it's good to just have more access for everybody, even if it's not being taken full advantage of by every type of person. But it's certainly possible that we went to these communities and found the same types of patients we were already finding. So that's that would be maybe the pessimistic or cynical way of looking at it. I'm not sure. We'd have to look at it a little bit with even more granularity, and I'm not really honestly sure if that's possible.
Do we know if the way that PD was expanded was the way that the policymakers intended when they introduced these programs? Like, did the financial incentives operate as intended, or was this sort of an accident of the policy, or a nice byproduct of the policy?
I think a nice byproduct, to be honest. I think with the exception of with payment for training. So there was some thought process put into this in 2011. I don't know who it was in 2009, 2010 when this rule was being made, to make it more equitable. Like, again, if we're not paying patients, if dialysis organizations aren't getting paid to train PD patients, which they weren't at nearly the same rate in 2011, they're just not going to do it, right? To the extent that rule worked, was the bundle really meant to improve access to home dialysis? I don't know. I kind of think that that's more of an accident, but I think that somebody was intentional, whoever they were, thanks to them, about making it possible to get paid for home training, and that has worked out. I think somebody is happy with how that went. And it's really interesting to contrast it to 2021, this newer era where there was a huge intention and a stated goal to increase PD to even like 80% of some. I mean, there were just some astronomically high estimates and we have not seen anything like that, right? And so it's always interesting how things work out when we didn't intend for PD, when weren't thinking that PD was going to did change a lot. And when we were like, we have to change this and we're going to incentivize it, it really didn't move the needle much.
Mm-hmm. And just to put it into context, for those who haven't read the paper yet, at the patient level, the rate of PD use among incident patients over this period went from something like 8% of incident patients choosing PD to about 11 or 12% choosing PD. Do I have those numbers correct?
I can't remember. I thought it was something like 15, but I may be going
Okay.
back to present as opposed to 2020. I'd have to think about it. It's nearly a doubling of the prevalent PD population over that time. So but you can look at it like, 8 to 12% or 8 to 13. I'd have to think about it. I'd have to look at the numbers, but you look at that and say that's not that impressive. But you could say there's 70% more PD patients than there were in 2009, and that's a big change.
Do we know, this wasn't the topic of your paper, but I'm just wondering, do we know from other research if these new patients, the ones that we weren't previously reaching with PD therapy, do they have the same rates of technique failure? Do they stay on PD for as long as the previous cohorts?
Well, thank you for asking, because I did have a paper that I published a couple of years about with my co-author group, with a similar co-author group, about that question: is are we seeing, did we expand to new patients that may not do quite as well with PD? Is maybe the question you're sort of thinking about. And they did just as well. We did not. In terms of mortality, there was no difference. In terms of technique failure has really not improved in for PD very much. It is improved much slower than mortality, and of course that may be more to do with the fact that mortality has, huge numbers of causes. For somebody's cancer cures could get better, all that. Technique failure has not improved that much. Maybe gotten better, like 1% or 2% better over the last 10 or 20 years. But you could look at that as saying, well, why aren't we getting better? Or you could look at it and say, we have many, many, many more PD patients than we did, and they're actually doing just as well as they used to, if not just a teensy bit better. Peritonitis was another thing I looked at a while back, and that also has continued to improve greatly. Our peritonitis rates have gone down much faster than our technique failure rates. When that has maybe more to do with changes to practices of antibiotic prescription, and are we catching it? Are we diagnosing it more? It's a little bit easier of a problem to address the many factors of technique failure. And so that's gotten much better. I think we can be really safe in saying that these folks that have come into PD since 2011, those patients did just as well as the folks did before, and maybe in some cases have done better, especially with just how long they're living and how much peritonitis they're having.
I'm just thinking about looking into your crystal ball of policy and what might come next. Can you speculate on what health system or policy changes would be needed to further increase PD? Is it possible? Or have we sort of tapped into, the best candidates for PD are already accessing the therapy and there's not that much more room for growth?
Yeah, I mean, I think a lot about one way of looking at this study is there was some low-hanging fruit in place in terms of PD patients that would do well with the therapy, that weren't getting the therapy because of where they lived, right? And from 2011 to 2020, we kind of picked some of that low-hanging fruit. And so since then, there really hasn't been quite as much difference in how many people are getting PD. Are there other incentives that would move the needle? I mean, I think we'd have to put our foot down. I think the federal government, turns out they'd have to weigh in. CMS would have to change much more. It would have to really directly incentivize providers a lot more than they're currently doing, because we know that if you just kind of I don't want to say fiddle around the edges, but if you just kind of change things, if you just kind of give providers a 1% bonus, or dialysis centers like a 1% bonus for increasing their numbers of home dialysis patients, that's not going to really move the needle. And just to be strictly honest with you, I mean, I research PD, that's my main area of research, and I see a lot of PD patients, and I think it's really important. It would be hard, like really giving really, really big financial incentives. Is that in line with all of the evidence that shows that PD and HD outcomes are pretty similar? You know what I mean? Should the federal government be saying everyone should do PD? I mean, that's really about your values, right? That's about what I feel like. I don't think the outcome data is there like it is for transplantation, right? Like people just do so much better with kidney transplants, but many people do much better with home dialysis, but it's not in the same category of improvement. It's a subjective quality of life improvement that's extremely important, but it's just not in that league of improving transplantation. So I don't know. I think the federal government would have to put in a lot more money. And I think I am not totally certain, but would love to hear from anybody about it. Like if that's justified, is basically what I would say.
Yeah, I think that's a really smart take on it. Well, this has been a really fascinating walk through health policy and its implications for peritoneal dialysis use. Also, maybe a peek into the future. I've really enjoyed this conversation. It was great to talk with you, Dr. Knapp.
Oh, thank you. It was great to talk with you.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.